Chapter 6 Genetics. Condition Trisomy 21. Caused by an extra chromosome at number 21, this condition occurs from birth and is systemic. Clinical features include slanted eyes, flat face, short stature, gingivoperiodontitis, a fissured tongue, and hypodontia. Treatment includes root scaling and planing, and diagnosed by a karyotype that's shown in trisomy 21. Trisomy 13. Caused by one extra chromosome at number 13, this again occurs from birth and is systemic. Clinically, a bilateral cleft lip or cleft palate, or maybe both, is present, with polydactyly and microphthalmia. Radiographically, an extra finger in the hand can be seen, and is also diagnosed by the karyotype shown in trisomy 13. Turner syndrome. One X chromosome is missing, which is the cause, and it occurs at birth in women. Location is systemic and is clinically shown as a short stature, webbing of the neck, and edema of the hands. Microscopic features no bar bodies in buccal smear, and diagnosis process includes karyotype shown absence of X chromosomes. Klinefelter syndrome. Caused by one or more X chromosome, it occurs in men from birth, and its location is systemic. Clinically, the features are tall stature and gynecomastia, and radiographically you can see a hypoplastic mandible. Microscopic features include one bar body in buccal smear, and diagnostic process include a karyotype shows 2 or more X chromosomes. Cat-Cry syndrome. Caused by deletion, it occurs in men and female equally and occurs at birth. It is systemic, and clinical features include a cat-like cry, severe mental retardation. Treatment includes dental care for mentally handicapped, and diagnosis includes karyotype showing deletion of short arm of chromosome number 5. Cyclic neutropenia. Caused by autosomal dominant gene ELA2, it occurs from birth and occurs in equally between men and women. Location is the oral mucosa and the periodontium. Clinical features include gingivitis, periodontitis, ulcers, and hemorrhage. Radiographically, alveolar bone loss and pocket formation can be seen, and microscopically, diminished neutrophils and peripheral blood. Treatment is root planing and scaling, and antibiotics, and diagnostic process include clinical and blood studies. Papillon-Lefevre syndrome. Autosomally recessive, it occurs in both women and men and is from birth. The location is the gingiva, periodontal ligament, palms, and soles, and clinically can be seen in tooth mobility, pockets, palmoplantar keratinosis or hyperkeratinosis. Radiographically, alveolar bone loss can be seen, as well as severe periodontal disease. Microscopically, profuse inflammatory infiltrate or soft dental tissue. The treatment includes scaling and root planing, tooth fixation, and retinoid for skin lesions. Diagnosis process includes clinical and genetic evaluation. Focal palmoplantar. Autosomally dominant, from birth, and it occurs in male and female equally. The location is the gingiva, palms, and soles, and clinically can be seen as keratosis of gingiva, of the palms, and of the soles. Microscopically, hyperorthokeratinosis of the affected area. The treatment is maintenance of oral hygiene and can be diagnosed clinically and using family history. Laban syndrome. Autosomally dominant, occurs from birth, and male and female are equally affected. The location is in the gingiva, and the gingiva clinically is marked with hyperplasia, abnormal nails, short fingers, and toes. Radiographically, hypoplasia of terminal phalanges of the fingers and toes, and microscopically, profuse fibrosis and increased collagen of affected gingiva. The treatment includes maintenance of oral hygiene, surgical remodeling of gingiva, and can be diagnosed clinically and through family history. Gingival fibromatosis, hypertrichosis, epilepsy, mental retardation syndrome occurs from birth between male and female equally and is autosomal dominant. Gingiva, hair, and central nervous system are affected and clinically can be seen as gingival hyperplasia and abundant body hair and epilepsy. Microscopically, profuse fibrosis and increased collagen affecting the gingiva and can be maintained using maintenance of oral hygiene, surgical remodeling of the gingiva, and can be diagnosed clinically and through family history. Gingival fibromatosis with multiple hyaline fibromas. From birth and occurring in both male and female equally, it is an autosomal dominant cause. Location is the gingiva, nails, mucosa, and skin. Clinical features include gingival hyperplasia, hypertrophy of the nails, and multiple tumors. Microscopically, fibrosis of the gingiva, hyaline fibromas. Treatment includes maintenance of oral hygiene, removal of the fibromas, and can be diagnosed clinically and through family history. Cherubism, caused by autosomal dominant, occurs in both male and female, and from birth. Location is the mandible bilaterally. Clinical features are bilateral enlargement of the face. Radiographically, multiple bilateral radiolucencies of the mandibular ramus. Microscopic features include multinucleated giant cells in the loose connective tissue. The treatment includes lesions will fill in after puberty, and diagnosis process includes clinical and family history as well as radiographs. Ellen van Creveld syndrome. Autosomally dominant, occurs from birth between male and female. Location is the gingiva, teeth, alveolar ridge, and the hands. Clinical features include absent upper vestibule, serrated lower alveolar ridge, and polydactyly. Radiographically, a thinning of the enamel can be seen, and the treatment includes reconstruction of the upper vestibule, amputation of extra fingers. Diagnosis is usually clinical and family history. Cleidocranial dysplasia. Autosomally dominant, occurs from birth and is equally seen in male and in females alike. Locations of teeth, the clavicle, and the skull. Clinically can be seen as supernumerary teeth, absent clavicles, and open fontanelles. Radiographically, multiple impacted teeth can be seen, and microscopically, an absence of cellular cementum. The treatment includes extractions and orthodontia, and diagnosis includes clinical, family history, and radiographs. Gardner syndrome. Autosomally dominant, found equally in male and female, and occurs from birth. The location is the maxilla and the mandible. Clinical features include multiple osteomas, colon polyps, and adenocarcinomas. Radiographically, odontomas and osteomas in the jaw can be seen, and the treatment includes surgery for the polyps and or carcinomas, odontomas, and osteomas. Diagnosis process includes clinical and family history as well as radiographs. Mandibulofacial dysostosis. Autosomally dominant, occurs from birth and equally between male and female. The location is the mandible, the teeth, and the ears, and clinical features include hypoplastic mandible, malapposed teeth, and deafness. Radiographically, obtuse mandibular angles and small condyles can be seen. Treatment includes plastic surgery, orthodontia, and maintenance of oral hygiene, and diagnosis includes clinical and family history as well as radiographs. Nevoid basal cell carcinoma syndrome. Autosomally dominant, occurs both in male and female alike from birth. The location is the mandible, the maxilla, and the skin. Clinically, multiple odontogenic keratosis and basal cell carcinoma can be seen. Radiographically, multiple radiolucencies of the jaw, and microscopic features include reviewing odontogenic keratosis and basal carcinomas. As treatment is surgical removal of the cysts and the basal cell carcinomas, and the diagnoses include clinical and family history as well as radiographs and microscopes. Osteogenesis imperfecta. Autosomally dominant, multiple genes are involved. It occurs from birth and occurs in male and female equally. Location includes the skeleton and the teeth. Clinically, it can be seen as blue sclera, multiple spontaneous bone fractures, multiple skeletal deformities, and dentogenesis imperfecta like teeth. Radiographically, small teeth, crowns of roots, small pulp chambers, and skeletal changes can be seen, and diagnosis usually includes clinical, family history, and radiographs. Hereditary hemorrhagic telangiectasia. Autosomally dominant, starts after the teens and occurs in men and females equally. The mucous membrane and the skin are affected, and clinically can be seen as telangiectasia and gingival bleeding. Capillary dilations can be seen microscopically, and the treatment includes care must be taken during scaling because of marked bleeding tendencies, and can be diagnosed clinically and through family history. Multiple mucosal neuroma syndrome. Autosomally dominant, occurs from birth and is equally seen in male and female. Location is the oral mucosa, especially the tongue. Clinically, it can be seen as multiple nodes on the tongue tip, lips, and cheek mucosa. Microscopically, neuromas, thyroid carcinomas, and pheochemocytomas. Treatment includes preventive thyroidectomy and excision of the oral neurofibromas. Diagnosis includes clinical and family history as well as microscopic. Neurofibromatosis of von Recklinghausen. Autosomally dominant, occurs from birth between male and female equally. The locations of skin, oral mucosa, especially the tongue. Multiple nodes of the tongue and other mucosa can be seen clinically and radiographically. Spine anomalies, radiolucencies in the mandible can be seen. Microscopic features include neurofibroma. Treatment includes surgical removal of the neurofibromas, and it can be diagnosed clinically and through family history and microscope. Peutz-Jeghers syndrome, autosomally dominant, occurs from birth and it occurs in men and women equally. It occurs on the skin, oral mucosa, and small intestine. Clinically, pigmented macules and perioral skin and oral mucosa can be seen. Radiographically, intestinal polyps are seen. Microscopically, melanin apposition in skin and oral mucosa. Treatment includes the removal of intestinal polyps if needed and can be diagnosed clinically and through family history. White sponge nevus, autosomally dominant, mutations in mucosal keratin, K4 or K13, from birth or develops at puberty, occurs equally in men and in women. The location is the buccal mucosa and clinically can be seen as bilateral whitening of buccal mucosa. Microscopically, an abnormal thick layer of orthokeratin and clear cells. Treatment include maintenance of oral hygiene, and it can be diagnosed clinically and through family history as well as microscopically. Ameliogenesis imperfecta pitted hypoplastic, autosomally dominant, visible when teeth erupt. Both men and women have an equal chance of getting this condition. All primary and permanent teeth are affected. Clinically, random pinpoint pits and labial-lingual surfaces are seen. Radiographically, enamel is thinner than normal. Microscopically, abnormal enamel matrix, and that is thinner than normal. And the treatment, aesthetic, dentistry, and operative procedures. It can be diagnosed clinically and through family history. Ameliogenesis imperfecta hypocalcified type, autosomally dominant as well as autosomally recessive when teeth erupt, and it occurs in both men and women equally. All primary and permanent teeth are affected, and clinically the enamel seems cheesy and soft, rapid loss of enamel as well as an anterior open bite. In radiographs, enamel has a moth-eaten appearance. Microscopically, enamel of normal thickness and poorly calcified. The jackets and crowns, metallic crowns, and aesthetic dentistry are types of treatment, and diagnosis includes clinical and family history. Ameliogenesis imperfecta hypomaturation type, autosomally dominant, autosomal recessive, and X-linked recessive. It occurs when the teeth erupt. Autosomally dominant and autosomally recessive occurs both in men and women, and X-linked occurs more in men. All primary and permanent teeth are affected, and clinically, the enamel appears softer than normal and chips easily. Radiographically, enamel has some radiolucency as dentin, has the same radiolucency as dentin, and microscopically, large amounts of enamel matrix. The treatment includes jacket crowns, metal crowns, and aesthetic dentistry, and can be diagnosed clinically and through family history. Ameliogenesis imperfecta snow-capped, autosomally dominant and X-linked recessive. It occurs when the teeth erupt. The autosomally dominant occurs in men and women alike, but while the X-linked occurs more in men. All primary and permanent teeth are affected, and clinically, white discoloration of the surface of the enamel and occlusal 1/3 of all teeth. Treatment includes aesthetic dentistry if the patient wants it, and it can be diagnosed clinically and through family history. Dentinogenesis imperfecta, autosomal dominant. It occurs when the teeth erupt, and the location is all primary and permanent teeth. Clinical features include bulbous crowns, opalescent brown bluish crowns, and radiographically short pinpoint roots absent pulp chambers. Microscopically, abnormal globular dentin and trapped osteoblasts. The treatment includes aesthetic dentistry, crowns, and operative procedures. Diagnosis can be done clinically and through family history. Radicular dentin dysplasia, autosomal dominant, and it occurs when the teeth erupt. The location are all the primary and permanent teeth, and the clinical features include normal crowns in size and color. Radiographically, however, there are short pinpointed roots and absent pulp chambers, microscopically abnormal tubular dentin, and osteodentin. The treatment includes prosthetics if teeth are lost and can be diagnosed through family history and radiographs. Coronal dentin dysplasia, autosomal dominant, it occurs when the teeth erupt and it affects all primary teeth. Clinically, primary teeth are amber in color and permanent teeth are normal. Radiographically, primary, absent pulp chambers, permanent molars, and bowtie pulp, uniradicular teeth, and thistle-shaped pulp, while microscopically abnormal dentin in primary teeth and permanent teeth with pulp stones. The treatment includes regular dental and dental hygiene care and can be diagnosed radiographically as well as clinical and through family history. Hypohidrotic ectodermal dysplasia, X-linked recessive. It occurs from birth, and the X-linked are all males, while autosomal recessive occur in male and female alike. The location is the skin, sweat glands, hair, and both dentitions. Clinically, few teeth are formed. Hypokeratosis, hypohidrosis, frontal bossing, depressed nasal bridge, and protuberant lips. Radiographically, almost no teeth are present, and microscopically, reduced and abnormal sweat pores. The treatment includes dental implants and or dental prosthetics and can be diagnosed clinically through family history as well as radiographically. Hypophosphatasia, autosomally recessive. It occurs from birth and is occurrent in both men and women equally. The location is the bones and the teeth. Clinically, premature loss of primary anterior teeth. Radiographically, large pulp chambers can be seen, and an absence of root cementum is seen microscopically. The treatment includes space retainers and or dental prosthetics, and the diagnosis process includes clinical and family history as well as radiographic. Hypophosphatemic vitamin D resistant rickets. The cause is a X-linked dominant, and it occurs from birth more often in men. The location is the bones and the teeth. Clinically, the features include multiple peripheral radiolucencies, cysts, and granulomas. Radiographically, large pulp chambers and large pulp horns can be seen. Microscopically, abnormal globular dentin as well as large cracks in the dentin can be seen. The treatment includes endodontics and regular dental hygiene care and can be diagnosed clinically through and family history as well as radiographs.